Hello. Excuse me. Today I'm going to talk about chest pain. It's important to realize there's several types of chest pain. Commonly, acid reflux may occur in association with coronary disease. And so it's important to know the difference and to go through these symptoms with the patient. I'm going to talk about angina first. So angina or coronary pain is often not thought of as pain by the patient unless they are having a severe problem. It is usually described as a vague substernal discomfort. It may be pressure-like on their chest. If it's severe, it may be like an elephant sitting on their chest. It can also be in the upper abdomen when the lower part of the heart is affected, and can present as abdominal pain. It can present as teeth pain if the pain is radiating to the teeth, or can radiate to the back in between the shoulder blades. So it can be quite variable. Typically, coronary pain is associated with exercise or activity and then goes away when at rest. It is generally said that if the discomfort lasts longer than 20 minutes, then it's indicative of a heart attack. So if it is not, then the patient has a history of this discomfort and it's not unusual in nature, then they may just take a nitroglycerin or something like that, and it may resolve. However, if the pain is persistent, or if there's a change in pattern, or if it's becoming progressively worse, it demands immediate attention and will be called unstable angina if it's coming from the heart. You can also have chest pain from dissection of the aorta, where the pain is in the back and works its way down. There can be many causes for chest pain. In gastroenterology, we get involved with non-cardiac chest pain because most of the time it's acid reflux. I was in favor of investigating and making a diagnosis of acid reflux. I would often use upper endoscopy, or certainly pH probe testing can be very valuable. The pain in coronary disease is from decreased blood flow to the heart. A heart attack is when the blood flow has been so compromised that the tissue dies. Myocardial infarction, it is referred to. It can radiate, as I mentioned, to the teeth. The patient may be in the dentist chair. Can radiate to the shoulder, may be seen in orthopedics. Can be confusing at times. Most of the time, you're not really sure what's going on with the patient, and they oftentimes demand immediate attention and are in the emergency room getting EKGs and blood work tests and being closely monitored on a cardiac monitor. In general, if the patient has chest pain and their EKG at the time of the chest pain, and they have to be having chest pain at the time the EKG is done, looks normal, that's reassuring. Of course, there's been many patients, unfortunately, who drive themselves to the emergency room and don't make it, or they are evaluated and they look okay by the emergency room doctor, and then they have an arrest and die in the parking lot after their evaluation. So always best to proceed with caution, admit the patient, observe the patient, always assume the worst is going on, and that way such things won't tend to happen. Remember that chest pain, that coronary pain rather, can present as upper abdominal pain, so it must be kept in the differential, and particularly a lower part of the heart or inferior wall MI or ischemia, where the heart is not getting enough blood, can present this way. There can also be psychological causes or psychiatric disorders such as anxiety attacks or panic disorder that can present with chest pain. So, and oftentimes they can be associated with one another. A patient can be having coronary disease and associated with that a panic attack, or they can have reflux in association with coronary disease and heart attack and panic attack associated with that. So it can be confusing. So you may want to go ahead and dissect, and you may need to go ahead and dissect out the symptoms to try and discern what's going on. Are there more than one thing going on? In terms of the esophagus, I always like to take a look with the endoscope in patients who had non-cardiac chest pain, or they came through the evaluation and nothing was found. But often I found that such patients were not referred for GI evaluation. They were simply discharged, and some of them were given instructions to take antacids as needed or acid reflux medication, but many of them were not evaluated, and that I think is a neglectful thing on the part of physicians. What you want to do is evaluate patients and try to figure out what happened to them, why did they have to go to the emergency room, what is the whole story here, because some of them may have very significant acid reflux or other conditions other than cardiac issues that have led them to come to the emergency room. So I think with that, I'm just going to go ahead and conclude this particular talk, and keep in mind, I think there's more detail in the chapter I wrote on chest pain. Thank you.